Okay, so this is part 2 of the Eli Physiology review. I'm going to finish up the mastery questions and then take you through a couple questions from the CBCL activity that I thought were particularly relevant to physiology. You have mastery question number 10. A patient presents to your clinic for a routine checkup. Her blood pressure is 140 over 100, which is quite high. Estimate her mean arterial pressure. Okay, so first thing, recognize that this is an estimate, okay? But you can quickly estimate what this is by using the formula here, 2 times diastolic pressure plus systolic pressure divided by 3. There is another formula in the notes which also works. It's basically the same formula rearranged. You can use either one. I kind of regret giving you that second formula. I think this one's easier to understand. It's easier to explain. And I'll probably change it in the notes for next year, but for now you can use either one. I assure you they're exactly the same, they give you the same result. The reason this is what it is because, of course, common sense, the average person would tell you that the mean is 120, for this pulse, is 120 minus 80 divided by 2, which will give you 100. In this case, it would be 140 minus 100 divided by 2, which will give you 120. Halfway in between these two, halfway in between those two is 100, halfway in between these two is 100. In fact, it's not, it's slightly lower than that. The reason is because what we're calculating here is the time averaged mean, which is what your carotid detects, which is why it's physiologically relevant. Your carotid is detecting pressure all the time, all the way through this increase and all the way through diastole. It's not, it doesn't have brain cells of its own where it can pick off the peak and pick off the trough, send it to the nucleus, divide the difference by 2, and go, okay, it's 100. It doesn't work that way. It just monitors the pressure all the way through this pulse, and it outputs something proportional to what it sees over time. So in order to calculate the mean arterial pressure, you have to get the time averaged mean. You spend roughly twice as much time near diastole as you do near systole during this pulse. So you multiply the diastolic pressure times 2 and the systolic and divide by 3, and you get the correct pressure, which is 113 in this case, okay? Blood volume is higher in which compartment of the cardiovascular system? This is right out of the self-study. It is the veins and venules. That should make sense to you. You've had histology now too. You know that the veins and venules, fairly thin-walled, they're really designed to have a high compliance, which means they're designed to hold a large volume at a low pressure. And so the veins and venules are designed to hold more blood, and it, for all practical purposes, holds this blood in reserve. So for instance, if you hemorrhage blood, and you increase sympathetic activity, these walls of these veins and venules, the smooth muscle contracts, the resistance goes up a little bit, but the major effect upon the cardiovascular system as a whole is to reduce the compliance of the walls of those veins. And so what you get is you get stiffer walls, and at the same pressure, you're holding less volume, and so this volume is ejected out into the cardiovascular system, and it helps maintain arterial pressure when in the face of a hemorrhage or a blood loss. So that's why it's physiologically relevant. Okay, so let's talk a little bit about the physiology exercises from the Eli Whitney case session. So the first question that I had a lot to do with was question number 2 in the exercise here. And it's a question which is simple enough. It asks, in a child which has a VSD only, which way does the blood flow through the VSD? So here we're assuming that this is a child that's very early on, that doesn't have Eisenmangers or anything like that, okay? And so this is a very simple exercise, a very simple explanation. Blood flows from high pressure to low pressure. And so you know that the left ventricle has a higher pressure during systole, about 120, than the right ventricle, which is about 1/5 of that during systole. And so blood will flow from high pressure to low pressure through this hole between the ventricles, from the left ventricle to the right ventricle, okay? So then I gave you this oxygen data that you see here. And if we walk through it, the oxygen content of the vena cava, 67% saturation, that's pretty low, which it should be. It's venous blood coming back into the right heart. The oxygen content in the right atria should be the same as the vena cava, and it is. And the oxygen content of the right ventricle should be the same as the right atrium, and it is. Okay? So far so good. Now we've got Eli here, and this is during a cyanotic event. So we're trying to figure out exactly what's going on. So we look at the oxygen content of the pulmonary artery. That should be the same as the right ventricle, and it is. This is 97. It's 67 in your student guide. It's 67 in your faculty guide, which is correct. It's still 67% saturated. It's a misprint on my part. Then we go to the pulmonary vein, and we see that we have a higher hemoglobin saturation, 97%, and that's normal because your pulmonary vein is coming back out of your lungs, and blood is being returned this time to the left heart. So if we look at the left atrium, it should be the same as the pulmonary vein, and it is. Now we look at the left ventricle, and all of a sudden we see a drop in the content, and the hemoglobin saturation is down a little bit. And then we look at the oxygen content of the aorta, and it's down even more. So the question is, what's going on? And the answer is that blood is being added from the right heart to the left heart through the VSD in Eli's heart. So Eli has tetralogy of Fallot. VSD is one of the defects, and you have blood flowing into the right ventricle. And then you also have deoxygenated blood being added to the aorta directly from the right ventricle because of the overriding aorta, and that explains this drop here, okay? But the real question is, so if in a VSD, blood should flow from left to right, why is Eli's blood flowing from right to left, okay? As you see here in this diagram, the blood is flowing from right to left. Eli's probably crying during this measurement, and he has right to left blood flow. So the answer to this question has to do with, number one, the stenotic pulmonary valve that is part of tetralogy of Fallot. A stenotic valve, as you guys know, is a narrowed valve, okay? And so you get an increase in resistance to flow. Resistance is like kinking a hose. The pressure upstream of the kink goes up, and the pressure downstream of the kink goes down. Okay, so if I add resistance to the flow pathway, it's going to raise the pressure in that pathway before the point of resistance and drop it afterwards. In this case, the point in the flow pathway before the point of resistance is the right ventricle, and the blood and the pressure is going up in the right ventricle. And if we add the increase in resistance to flow in the lungs that you get when Eli cries or something like that, to the effect of this stenotic pulmonary valve, what you get is a buildup of pressure in the right ventricle to the point where it exceeds the pressure in the left ventricle, and now you get right to left flow, and now you get cyanosis. Okay, so that's the explanation to this this problem. It's this increase in resistance that you get, particularly due to the stenotic pulmonary valve, that causes this reversal of flow. Okay? All right. So we asked you to draw similar box diagrams for other defects, and those are over there. And Dr. Wilson is really as responsible as anybody for that exercise, being both anatomy and embryology. But what I wanted you to do after looking at these boxes was predict which ventricle, the right or the left, would you predict would be hypertrophied in a patient with ASD, which for a patient with PDA. Explain your reasoning. So the first thing is, instead of hypertrophied here, I should have said enlarged. And I'll talk to you why that is in a second. So for an ASD, the key to the answer to this question is to ask yourself which ventricle is pumping the extra blood. The ventricles that is pumping the extra blood is the one that's going to dilate, and that it actually is a dilation, not hypertrophy, when you're talking about volume overload, which is what this is. But the bottom line is one of the ventricles will get bigger than the other, and it's because that ventricle is handling more blood. So for the ASD, here, if we follow the flow pathway and we get blood flowing through the lungs, it's returned to the left atrium. The abnormal blood flow is from left to right, from the left atrium to the right atrium. And that blood from that abnormal flow is being added to the blood that's being returned to the right atrium normally from the system through the vena cava. So now I have more blood entering the right ventricle. The right ventricle has to pump all that blood out and back in through the lungs, okay? Where it's returned to the left atrium and it's split again, either going through the ASD or into the left ventricle, okay? So the extra volume is in this circuit, and it's all being pumped by the right ventricle. So in an ASD, you'll see a larger right ventricle than left ventricle, at least initially, before adaptive changes start to take place. And that's due to the fact that the right ventricle is volume overloaded and it's actually dilating, not hypertrophy, okay? Let's take a look at PDA. So we have that one right here. So now we have our blood coming from the lungs, going to the left atrium, to the left ventricle and out. But now we have our abnormal flow pathway, and that abnormal flow pathway is being added from the aorta into the pulmonary artery. And then the blood is being returned to the left atrium. So now when we look at the ventricle that's doing the extra work, that is the ventricle that's pumping the extra volume, now it's the left ventricle, because the left ventricle is pumping both the volume that's entering the body, the system, and the volume of blood that's entering the pulmonary artery. So there's extra blood being returned to the left heart. It's being split from the aorta into the pulmonary artery, but up to that point, all that extra volume has to be pumped by the left ventricle. So it's your left ventricle that's pumping the extra volume in the case of a PDA, and it's the one that patent ductus arteriosus, and it's the one that is going to enlarge and dilate in order to do, when you do that, okay? So that's the answer to that question, okay? I also asked you what the normal pressures are in an infant, and I told you you might have to look it up on the internet. That turns out to be wrong, because you could actually look at Eli's data where the normal blood pressures are actually given in the data. But the systolic, 61 to 79, diastolic, 30 to 54, so those are considerably lower than what you find in an adult. So the next question was, why do you think those values are lower? Well, the bottom line here is that the mean arterial pressure in the aorta, in the arteries, in a normal infant is lower. So now the key is to look at the things that determine mean arterial pressure. And the two things that determine that are cardiac output and total peripheral resistance. Okay? So we have two possibilities. It could be either the cardiac output is down or the total peripheral resistance is down. We know that the cardiac output is determined by heart rate and stroke volume. So what we're really saying is it could be a decrease here, or a decrease here. Any of those three, or any combination of those three, could cause the mean arterial pressure to be lower. As it turns out, the heart rate in an infant is really high. Okay, so that is unlikely to be the cause of a low MAP. If anything, a high heart rate should cause a high mean arterial pressure. But when you think about the size of an infant's heart, it should make sense to you that the stroke volume is going to be much lower in a baby than it will be in an adult human heart. So the stroke volume is certainly down in a baby, and that's one potential explanation. The other thing is, when you look at the amount of tissue that's being perfused, it's lower in a baby. There isn't as much. There aren't as many arterioles. There isn't as much vasculature to perfuse. And so the resistance to flow is down in a baby as well, okay? So it turns out that the reason for the low mean arterial pressure is because the total peripheral resistance is down because there's less tissue to perfuse. And the stroke volume is down because the heart's smaller, okay? And that's the reason why, all right? And finally, we have the Wiggers diagram. So I asked you to draw a Wiggers diagram for Eli. But let's go through a normal one first, okay? So here, I usually start about right here where the heart is filling with blood. And the top line here, this isn't in color, but the top line here is the atrial pressure. The bottom line here is the ventricular pressure, and you know that because you're feeling the heart. Blood is flowing from the atrium to the ventricle, so the pressure must be higher in the atrium than in the ventricle, okay? And the blood is filling, or the left ventricle is filling. This is the left, you know that because the pressures are high. If it was the right, they'd be low, okay? But the same events are going on the right side as are going on the left, just at lower pressures. So now we look at our EKG, we see our P wave, and we know that that is what you get on an EKG when you get atrial depolarization, and the atria begin to contract, and you see that because the pressure in the atrium goes up here. And the pressure in the ventricle goes up as well because you're shoving that extra blood into the ventricle, okay? And you see that increase in volume here in the left ventricular volume. And now you see we have our QRS complex in our EKG, and that means that our ventricle is depolarizing, and that means that our ventricles are beginning to contract, and in response to that we get an increase in ventricular pressure. So the ventricular pressure goes up, it exceeds the atrial pressure, the mitral valve, the atrioventricular valve on the left side closes, and we hear S1. Okay, our heart sounds are down here. You can't see the heart sound very well. I posted the slides so you guys can look. But S1 is right here. Okay, you get the first heart sound. Our pressure then rises and we enter a phase called isovolumetric contraction. Isovolumetric because both the mitral valve and the aortic valve are closed. Blood has no way to get in or out, so the pressure is going up, but the volume is not changing, and you see the left ventricular volume is steady here. Then the pressure eventually exceeds the pressure in the aorta. The aortic valve opens, and we begin to eject blood into the aorta, and the pressure goes up as we generate more and more pressure in the ventricle, and we shove that blood out into the aorta. We then get our T wave on our EKG, and that means that our ventricle is repolarizing and starting to relax, and in concert with that you see the pressure dropping here in the ventricle. Eventually the pressure drops below the aortic pressure and the aortic valve closes, and you hear S2, which you should hear in concert with that. We then enter isovolumetric relaxation. Again, isovolumetric because both valves are closed, the volume is not changing. The pressure eventually drops below the atrial pressure again, and we begin to fill the ventricle again, which you can see right here. Okay? So that's a quick round the horn in the normal Wiggers diagram. Now, let's take a look at what I wanted to highlight in Eli's. And the first thing I wanted to highlight was the fact that your isovolumetric contraction, and to a lesser extent your isovolumetric relaxation, are no longer isovolumetric. Your valves are both closed, but now you've got a hole in the heart between the ventricles, so blood can get in and out of the left ventricle through that hole, through the VSD. In this case, I've drawn it as if Eli were cyanotic. That is, he's crying or something. And blood is flowing from the right ventricle into the left ventricle, and the left ventricular volume is increasing. I could have just as easily drawn this with the left ventricular volume going down, with Eli not crying, and therefore with blood actually being transferred from left to right instead through VSD, because our resistance hasn't increased high enough in the right ventricle to exceed that left ventricular pressure. If he's not crying or if he's not cyanotic. So The isovolumetric phase is no longer isovolumetric. The left ventricle will get more blood. If Eli's cyanotic, it'll lose blood if he's not cyanotic. Okay, so that's number one. Number two is Eli has a systolic murmur, which I drew in here. The period of systole is while your ventricle is contracting. And so it's between S1, when the mitral valve closes, and S2, during the relaxation phase, when the aortic valve closes. That's when you'll hear this murmur, okay? So you might ask yourself, what's causing this murmur? The flow through the VSD can cause this a little bit, but most likely the primary cause here is the pulmonary stenosis, okay? So if we, let's take a look at this table, which describes what kind of heart sounds that you get with different valvular problems, so we can see why pulmonary stenosis might be causing a systolic murmur. So here we have two kinds of valvular problems. We have stenosis and insufficiency. Stenosis is narrowing of the valve, of a fibrotic valve. Insufficiency is when you have a leaky valve, okay? S1 is lub, S2 is dub, okay? So if we look at our AV valve, we know that during filling, the AV valve, the mitral valve is open and the semilunar valve is closed. And the reason is because during filling, during ventricular filling, blood is flowing from high pressure to low pressure from the atrium into the ventricle through the open valve. And the aortic valve is closed because the pressure in the ventricle is really low and the pressure in the aorta is really high, and that's keeping that valve shut, okay? During ejection, it's the opposite. We have a closed AV valve and we have an open semilunar valve because now our ventricular pressure is high. We're shoving blood into the aorta, and during the ejection phase. And our AV valve is closed because the ventricular pressure is high, the atrial pressure is low, and that's holding that valve closed, okay? So now, let's say we hear lub, dub, swish. Lub, dub, swish. So the first thing you'll notice, the swish comes after S2, and that means it's happening during the filling phase, okay? So now, if we say that insufficiency causes a swish, and stenosis causes a whistle, we know that we have an insufficient valve, and we know that we're hearing it during diastole, during filling. After S2 and before S1, that's when your heart fills with blood. So we're looking for an insufficient valve during diastole, and we know that insufficient valves, those are leaky valves. So you're only going to hear those valves when the valve is actually leaking, which means when the valve is supposed to be closed. Nobody cares if a leaky valve is open. You won't hear anything unusual if a leaky valve is open because it looks just like a normal valve. It's open. It's when it's closed and it's leaking that you'll actually hear a murmur associated with it. So we're looking for a valve that's closed during diastole. So that would be during filling. Our closed valve is our semilunar valve. So this would be what you would hear if you had an insufficient aortic valve or pulmonary valve, okay? If you hear lub, dub, whistle, now it's still a diastolic murmur, but now it's a high-pitched whistle. So now you're looking for a stenotic valve, okay? And you're looking for a stenotic valve during diastole. So stenotic valves you'll hear when they're open, because they're narrowed and you're trying to force a bunch of blood through a narrowed valve. Nobody cares if a stenotic valve is closed. When it's closed, it looks just like a normal valve. It's closed. You won't hear anything different. It's when it's open and you're shoving that blood through that you'll hear the murmur. So you're looking for an open valve during diastole. In this case, that would be your AV valve, your mitral on the left, or your tricuspid on the right, okay? Lub, whistle, dub. Now we have a systolic murmur. This murmur is happening while the ventricle is contracting, after S1, and before the aortic valve or pulmonary valve closes, making S2. Okay? So now we're looking for a A valve during ejection that is open, because it's a high-pitched whistle, that would mean a stenotic valve. So we look and we see our open valve during ejection would be our aortic or our pulmonary valve. So here we have the kind of murmur that you would hear with an aortic stenosis or a pulmonary stenosis. And finally, lub, swish, dub, systolic murmur, low-pitched swish, meaning we're looking for an insufficient valve. We're looking for a valve that's closed during systole. And our AV valves, our mitral valve and our tricuspid, are the ones that are closed during systole, during ejection. So here we're looking at an insufficient mitral or tricuspid valve. So if we look at Eli, he's got a systolic murmur. And we know that he's got 4 defects. It's probably going to be a result of one or more of those. A stenotic pulmonary valve will show up when the pulmonary valve is open. That means during systole. So we have a systolic murmur, and we know that he's got a pulmonary stenosis. So we know that that is most likely what's causing that murmur that you see here. Okay? This crescendo, decrescendo murmur is most likely associated with pulmonary stenosis. It doesn't have to be. The VSD can also cause a murmur, but it's probably the pulmonary stenosis. Okay? All right. So that's all I've got. Thank you for your attention, and good luck on your exam.